Order, order. Welcome to the Public Accounts Committee on Thursday the 17th of September 2020. We're here today to discuss digital transformation in the NHS, a knotty issue that the NHS and Department of Health have been grappling with for many years. I should say this is work based on a National Audit Office report, most of the work, of course, which was done before COVID. So the report isn't directly linked to COVID, but obviously we would like to cover some of the issues around COVID as we have important witnesses in front of us today. So I'd like to introduce our witnesses. We have David Williams, who's the Director General for Finance and Group Operations and now the Second Permanent Secretary at the Department for Health and Social Care. So welcome back to you, Mr Williams. Matthew Gould, who is the Chief Executive Officer of NHSX, which is a new body set up to deal with some of these issues, and Sarah Wilkinson, who's the Chief Executive of NHS Digital. So really important witnesses when we look at the challenges faced with digital. But if I may, Mr Williams, I'd like to turn to you first on the money that's coming into the department for testing. On the 3rd of September, you announced £500 million for mass testing. But since then, we've had the Prime Minister talk about Project Moonshot. So can you tell us how much that £500 million is expected to buy, first of all?
Yes, that initial allocation is there to undertake some trials of new testing technology, to invest in new types of test kit with more rapid turnaround, so that we can develop a plan for how mass testing could be delivered in future. It's not intended to be the full cost of delivery of such a programme through the winter or into 2021. So it's primarily around investment in technology, proof of concept, trials and so on.
So you obviously had that money allocated to you. Have you got a plan yet to how to spend it? Has any of that gone out of the door in the last 14 days, or are you still working up plans to how to procure the research into new testing techniques? So there are plans in place and commitments have been made against that £500 million for small numbers of new types of tests for us to validate both in laboratory settings and then live in controlled trials. We are also investing in rapid scale sort of processing equipment for some of these tests as well. So we have a plan for committing that £500 million and indeed for how we might spend a modest amount of additional money beyond that. So how much have you committed so far out of that £500 million?
Pretty much all of the £500 million is now committed in terms of our plans. I can let you have a note of how much of that is on contract. Obviously, spend against the £500 million is spread out over a number of months.
So, then you mentioned contract, which is the next big issue. So, how have you approached contracting for something which is cutting edge science? Have you? Because obviously we've got the COVID Act, which doesn't require you to go through the normal procurement process. But can you just walk us through what you've done, how you've made sure that you, as a money man, are getting value for money out of these contracts?
So, where either there is a particularly clear sort of sole source supplier of a new technology, or the need for speed to getting to an assessment of new technologies is sufficiently important. We are using direct awards, but that's primarily to purchase initial quantities of tests with an assumption then that there would be an opportunity for downstream competition if that's the state of the market. I think as you look to ramp up testing capacity beyond the 500,000 tests a day that the Prime Minister has set out for the end of October, in practice we are going to be reliant on a range of different types of testing. And so the opportunity for more normal procurement processes, running through some of our procurement frameworks, including new Public Health England procurement framework that is coming on stream this autumn, will be there. But for now, our commitment is staged, and we undertake benchmarking on cost per test, for example, as a way of understanding the value for money that we're getting for the taxpayers' money that we're spending in this area.
Good. I'm sure the Treasury will be as glad to hear that as we and taxpayers are. Can I just ask, before I move on to Olivia Blake, the moonshot proposal, 10 million tests a day, big ambition. How much more money do you think you're going to need for that? How much will that 500 million buy towards moonshot?
Well, the 10 million figure, although reported in the press, is not the headmark that we are aiming for. I mean, it's in the nature of a moonshot type approach that you start off thinking quite imaginatively about what you might look to deliver, rather than building incrementally on the capacity that we currently have.
Very diplomatically put, Mr. Williams.
So I'm not currently expecting that will be the where we end up in terms of the level of testing capacity that we build. I think it's also an issue for us about how far, as we get into this sort of the role of testing in steady state, if you like, rather than simply getting through this winter, the balance between testing provided by the state for clinical reasons, patients in hospital, care homes, key workers, as opposed to testing to allow the opening up of normal life. It isn't necessarily that all of these need to be procured and paid for by the taxpayer.
Okay, well, thank you. On the issue of capacity, I'm going to ask Olivia Blake to come in. Ms. Blake, if you could unmute. Thank you. Over to you.
Thank you. And these questions are to Mr. Williams, if that's okay. So earlier in the pandemic, the reason for difficulties with capacity was reagents, and that was repeated a number of times. I just wanted to understand what the actual issue with capacity is at the moment. Is it the workers to conduct the lab tests in the lab space, or lack of PCR machines, or other such analysis?
Well, I'm not sure there's much more I can sensibly add to the information the Prime Minister and the Secretary of State have shared with the House this week. Dido Harding is giving evidence to the Science and Technology Committee later today. But what I think it is just worth highlighting is that, as the Prime Minister set out yesterday, we have a plan, a trajectory to deliver 500,000 tests a day by the end of October. We are essentially on track against increasing our testing capacity to meet that ambition. We are testing around, or capable of testing around, 100 times more people a day than at the start of the pandemic. So, whilst of course in a sort of population scale enterprise like this, there will always be day-to-day operational challenges, and those are addressed, identified and sorted out. The particular challenge we face at the moment is the mismatch between demand and capacity, rather than that capacity is falling short of where we expected it to be.
Okay, Ms. Blake.
Well, thank you for that answer. I don't think we really touched on what the actual issue is there. So I'm going to ask all the questions, because I had questions about whether it was one or the other. So these tests aren't rocket science. Do you not think that the money for Moonshot would be better spent on the current testing technologies and capacity? Mr. Williams.
Well, there are different use cases, and even within the current capacity, there are tests for which rapid turnaround is particularly important, and other tests for which accuracy is a more important factor. So we have a blend of testing routes now matched to the use cases. I think the point about investment in future technologies is that it might either allow us to deliver current testing activity more cheaply, more reliably, at greater scale, or with a quicker turnaround. Innovating in this space, I think, is a perfectly sensible thing to do.
Okay.
There's then a choice about how those new tests are deployed.
But that doesn't tackle the issue of the here and now and the second peak. So if the issue is lab space, can I ask you how many universities, research sites, private labs have been approached for their space?
I would have to ask Dido and the testing team to write to the committee with that information, I'm afraid.
Okay, and if the issue is recruitment of staff and how many staff we have, how are we going to recruit for the 4 new labs, and what is the size of those labs?
Well, as I say, there's a plan to increase capacity, which we are delivering. As part perhaps of follow-up information, we can set out how we get from the current level of testing capacity, around 250,000 a day, to 500,000 by the end of October, and what that means in terms of lab capacity, consumables, and staffing. But we are essentially on track with our capacity plan. The challenge is that demand has grown substantially faster than the capacity that we had planned to deliver.
Okay, so if the issue is recruitment, have you considered a similar call out to ex-scientists as was done with the NHS for nursing and medical staff?
Well, I'm seriously trying to avoid agreeing that that's particularly the challenge here. Let me ask the testing team to set out where they are on capacity, what comes next, and which are the particular potential pinch points that they are actively managing as we expand for the autumn.
I think that would be very useful for the committee, because I think it would be difficult to know how we know this money is good value for money if we don't know the actual issue. And then the final question is about key workers. Lots of key workers don't drive. In my own city, the 2 walk-in centres have now closed. I'm concerned about key workers not being able to access tests. Have you done any assessment of the impact of these closures?
The testing team look quite actively at the sort of delivery channels and which of those are best suited to which use case, whether it's key workers, NHS and social care staff, care homes, elective patients, and so on. So this is an area that they keep under active review. As you'll see, we redeploy testing capacity to particular areas of concern as part of our local intervention strategy. So it's quite a dynamic position, and a range of factors are taken into account on how best to deploy testing capacity, of which access and the ability of people to access particular channels is absolutely part of that.
The committee has also been concerned about care homes and testing in the past. How is this current issue impacting on the access of care homes to testing?
Let me just say on that, as I think the Secretary of State said to the House earlier in the week, we'll be shortly setting out the basis on which we are making prioritisation decisions for testing within the capacity that we have available. As that is set out, I think we'll see that protecting a meaningful level of testing capacity precisely for care homes, for staff and people in care homes is a high priority and factored into that prioritisation process.
Okay, thank you, Mr. Williams.
Thank you. Over to Sir Geoffrey Clifton Brown, if you can unmute, please, Sir Geoffrey. And Sir Geoffrey, got you. If not, we'll go to another colleague. But
yes, no, I've got that.
Thank you, Sir Geoffrey. Thank you.
Yeah, good morning, Mr. Williams. I have to say I've listened with exasperation to your replies because they haven't contained precise detail in such a serious situation. I'd have thought you'd have had the replies absolutely at your fingertips. So can we try one or two very precise questions? At this moment, what is the laboratory capacity per day to analyse and produce results of tests? I'm not talking about the capacity for testing, I'm talking about the laboratory capacity for actually producing results.
Yeah, and I'm afraid I'm going to have to fall back on my point that whilst I absolutely understand this is an interest of a topic.
Forgive me, it's not an interest, it's absolutely crucial to the whole COVID prevention strategy.
Yes, sorry, I absolutely get that it was a topic of high interest to the committee, central to our strategy as the Prime Minister set out at the liaison committee yesterday. Whilst I'm the accounting officer for Test and Trace, operational delivery capacity issues are run through Dido Harding and the team, and it would be more appropriate, I think, for her to provide the information that you want, and we can arrange for that to be done very quickly.
Well, I think
it's extraordinary you should come before this committee today. You must have high-level meetings every day and not know the answer to that vital question.
Well, my expectation is that some of this information will be set out by Dido at the Science and Technology Committee later today, but I think that's a more appropriate route than coming from me, given that these are issues which I do not have direct responsibility.
Right, let's try another one. You're involved in a form of rationing at the moment. How is that being done, please?
As the Secretary of State set out for the House earlier in the week, we are prioritising demand against the capacity that we have available, and more details on the way in which that prioritisation takes place will be set out in the next day or so, I expect. He set out to the House the top priority of supporting patients, then supporting staff in NHS and social care settings. I've just touched on the protection that we are giving to testing in care home settings more generally. We are continuing as well with an important range of surveillance testing. So the challenge really has been the...
No, we know all that, Mr. Williams. Can we try and keep these answers fairly brief, because we've got an awful lot to get through? If you can't tell us how it's being rationed, can you give us an assurance that anybody who's displaying symptoms in any area will be able to get a test relatively close to where they live?
Mr. Williams.
Well, it is clearly our ambition that people displaying symptoms should get tests and should get those test results back quickly, both so that they know what action to take.
It may be an ambition. It was a reality until about the last 3 weeks. So I understand the demand has gone up, but if in your rationing programme you should be able to give us an assurance to this committee, the rationing will be such that anybody who's displaying symptoms can get a rapid test relatively close to where they live. Otherwise, the whole COVID strategy is beginning to break down.
And that is certainly the intent, and I think that will be clear when the detail of the prioritisation process is set out by ministers in the next day or so.
Right, final question from me, you'll be glad to know. How far, you talked about these portable tests, how far off a reality are they? Because they will presumably obviate the need to go through a laboratory.
Yes, so look, we've been testing some in Southampton and Hampshire. We're looking to start another city pilot very shortly. So the intention is that we will be able to deploy these if those pilots work as part of our plan for managing testing capacity through this winter.
You haven't answered my question. How far off are they of a reality?
Well, it depends. I mean, the tests exist now. A number of them have been subject to initial validation. What we want to do is trial them to see both how usable they are, what results we get, and then be clear how they factor into our plans. It will be an issue to resolve over the coming weeks and very small number of months.
Thank you.
Thank you, Chair.
We'll leave it there for now. Obviously, we've got more to cover. I'm going to bring in James Wild before we move into the main session, so the other witnesses will get their moment. But James Wild, over to you.
Thank you, Chair. Another one from Mr. Williams. A particular issue that's happened in Norfolk is people that have registered for tests, been given a slot, then arrived at the mobile test station, but have been asked for a QR code, which the system has not given them, and then they've been turned away, despite the fact that no tests are taking place and there's a lot of capacity being reported. Do you think that's acceptable? And if not, what's going to be done to make sure that if people turn up, a common sense approach is applied, that where there's capacity, you can have a test?
Mr. Williams.
Yeah, look, I don't want to get into the specifics of that case, but the logistical and operational challenges of delivering testing in these sites is quite high. Common sense can indeed be applied where that makes sense, but I think the best thing there, I'm afraid, would be to do is for me to ask Guido and the testing team just to give you a specific response on the way in which the flow of individuals at test sites is handled when people are turning up do not always match the expectations of people that we have booked in.
That would be helpful, because as you can appreciate, it's incredibly frustrating when people turn up and the people who are conducting the tests say they've got 500 tests they can do, they've done 50, but unfortunately you don't have a QR code, so you can't have a test. And that's often after they've spent a couple of days trying to get the slot for that. One of the questions on your role as a county officer, what's the average cost of the COVID-19 tests that are taking place?
The average cost is not a particularly helpful number, I think. What I can send to you is really the range of costs. So for some of the tests that we are buying, we're buying just simply the test consumables, as it were, and then we are processing those through labs where we've contracted separately for capacity. Some tests we are contracting for an end-to-end service. So it's quite a blended average. To give you a broad sense, though, a lab capacity cost from memory of around £40 a test is a benchmark. If we need to surge, then I'm willing to spend more than that. The kind of mass testing non-lab capacity test that we're looking at will be less than £10 a go. So it's that kind of scale.
Okay, thank you. Well, it'd be helpful if you could give a note to the committee just with those blended points and setting that out in a bit more detail. Perhaps if I can turn to Mr. Gould now to talk a little bit about the contact tracing app, which in April was said to be coming in a few weeks. A lot of development was done, the Isle of Wight trial happened, then a whole reset was taken. I mean, why has it taken so long to work out how to do this?
I think it's sensible to put it in context. At the start of the pandemic, we were trying a lot of things that we knew were risky and experimental, both in technology but also in other areas as well. Some of them have worked out extremely well. Some of them haven't worked out in the way we expected. When we started, it was before the Google and Apple framework had been announced or developed. As soon as that, or very soon after that framework was announced, we set up a parallel strand of work so that we had optionality on what we did. We then, unlike a lot of countries, we then tested very extensively to make sure that we understood the effects of what we were planning to put out, how it was working and how people were interacting with it. On the basis of those tests, we shifted course, and as has been publicly announced, next week the app will be put out. It will have a lot more functionality though than just contact tracing. It will be a very good product, and I think it will really help.
Mr. Wilde.
Well, that's an important issue. I mean, when this was first talked about, it was talked as it was critical to successful contact test and trace. Then it sort of had the impression that it is a bit of a nice to have. So are you saying this is going to be a core part of test and trace, and what impact do you think it will have in terms of the percentages of people that are successfully traced?
When we started, the test and trace program wasn't set up, so it was sort of on its own, as it were. Since then, obviously, NHS Test and Trace has been stood up, and the app is sensibly now, I think, embedded in that program. And it won't just be a contact tracing app, it will be the sort of the digital part of that program. So it will have, as I said, other functions as well, give people information that will be useful to them. I wouldn't like to put a percentage figure on the impact it's likely to have, partly because there are so many variables, including the number of people who download it. Obviously, the more people who download it, the more impact it's likely to have.
And how are you, so you're launching next Thursday. I assume that's a hard fixed deadline that won't change. How are you going to get, because this depends, you say people downloading it, are you going to encourage hospitality and other venues to require people to use the app to come into their premises rather than, for example, writing things down on a bit of paper, because that will obviously drive uptake if you have to have the app in order to enter a premises. Is that something you're considering doing?
Yes, and I should just say, by way of background, that my team and I in NHSX took the app forward for the first stage of its development, but when NHS Test and Trace stood up, the process moved over to them. So it's not actually my team that's going to be launching it next week, although obviously we remain involved. In answer to your specific question, though, I mean, one of the, I think, key bits of functionality of the app that's going to be launched next week is precisely that. It'll be a QR code reader, so that when you go into a bar or a restaurant or whatever, they will hopefully have downloaded a QR code which they can display. App users can read that QR code, and it'll make contact tracing people who've been in that venue much easier.
Okay, Mr. Wilde.
Thank you. And you said that the responsibilities passed across. It might strike some of my constituents a bit odd that an organisation called NHSX has sort of passed this over to non-specialists, as it were, to develop the app. Is that fair?
No. I mean, I think the logic to it is it made perfect sense, and that this was a move that I helped initiate. It made sense that when NHS Test and Trace was stood up, the app should be really firmly embedded in that programme. It's not being developed by non-specialists. There are superb development teams that are working on it. It's got excellent leadership with a great deal of experience of developing technology. So I'm very confident it's in good hands.
Okay, one to go back to Mr. Williams. Again, from an accounting officer perspective, what's been the cost so far of the attempts to develop this app?
Well, look, firstly, just one point of context. As Chris Wormold and I think, both shared with the committee in previous hearings on COVID costs. Given the scale of the challenge, we have had quite a high appetite, consistent with protecting value for money for the taxpayer, for spending some money on developing innovations, techniques which may help us, even if the case was not proven at the time. The spend on the initial app was in the order of 10 to 22 million, some of which...
Sorry, you're saying in the order 10 to 20 million, so that's quite a big...
I think the figure I have in mind actually is 11 million, but Matthew...
11.8, I think, was what the Minister said in June. So in June, the Minister said, Lord Bethel said 11.8 million in June. So just going back to Mr Wild's question, what's the total cost now?
So on the new app, this is a forecast figure for spend on developing the app and then supporting it through the rest of the financial year. My estimate is that we'll be around £25 million for the new app.
Thank you.
So some of that will be, some of the spend on the first app is relevant to the app being rolled out from next week. But if you have a sort of 11 million figure for the first phase and then around 25 million for the second app. But Mr Gould may just want to give you some more precision.
Mr Gould.
Thank you. So we estimate now the cost of the first stage of development with the original app was 10.8 million. Of that, 0.8 million was actually focused on the Google Apple parallel track, which is now the one that's being developed. Of the remaining 10 million, we estimate 6 million was on development that would have been necessary regardless of which version we chose, so has led to capability, insight and so forth that underpins the current app. 4 million was specific to the version of the app which we moved away from.
Okay. Mr Wild, anything more from you?
Just one on the creation of the National Institute for Healthcare Protection. Obviously, Mr Williams, how are you going to ensure that Baroness Harding has access to the digital skills and capability that she will need in bringing those organisations together?
Well, let me answer that as a sort of twin track. So the immediate priority in bringing the organisations together is around making sure we have joined up operational delivery for the winter, as we then think about how, in parallel, we formally launch the organisation from April next year. Digital skills are, as you say, going to be critical to the success of the National Institute, whether that's in supporting the public through the user journey, delivery of the operational logistics operation on a day-to-day basis, or through data analysis of the progress of the disease. The resourcing questions really are a blend of moving digital experts within the department and wider civil service into test and trace roles, drawing on external support where there are particular skills that civil service does not have immediate or ready access to, a combination of short-term appointments where that makes sense for specific pieces of work, and indeed, as Mr Gould has highlighted in talking about the app, using expertise from NHSX and Sarah Wilkinson's organisation, NHS Digital, where they can play a supporting role as well. So we are taking a broad brush approach, multi-layered approach to ensuring that we have the right technical and digital skills in the organisation, both on launch next year, but critically through the winter period.
Thank you.
Thank you. So I think we need to now move on to the main session. And of course, on this issue, the issues we've been talking about, the National Audit Office is having a good look, hard look at the numbers, as well as you know, Mr Williams, we know you're the money man in the department. So hopefully we have a shared interest in watching these vast sums of taxpayers' money going out the door. We don't object to them being spent if they're delivering, but we will be watching closely the effectiveness with our sister committees, science, technology, health, and so on. So we now need to move on to the main agenda about digital transformation in the NHS, an ambitious programme that's, if you like, business as usual for the NHS, but not all delivered. So I'm going to ask James Wilde to kick off on the main agenda. So our other witnesses, I won't reintroduce them, will get their moment as well. Thank you. Over to you, Mr. Wilde.
Thank you, Chair. I mean, clearly the NHS Long Term Plan puts improved digital services at the heart of delivering on that plan and better services for the public, which is going to be a huge process and cultural change. Question for Mrs. Wilkinson. How far away is the NHS from delivering the government's ambitions on IT for the NHS?
Well, we've made huge progress in the last 3 years. So, within NHS Digital, we've delivered the 111 online system, we've delivered the NHS app, the NHS.uk website, which no doubt people are familiar with, multiple other services that were in the original plan, so the Child Protection Information Sharing System, the Summary Care Records, the vast majority, I think about 86-87% now, prescriptions around the system are electronic. All referrals from primary care to secondary care are now electronic. We have also built the Cybersecurity Operations Centre for the system, which has been enhanced significantly since the unfortunate WannaCry incident in 2017. And of course, I suppose more than anything else, what we do every day is we ensure that all of the core national systems are up and running, and we've run the most critical of these at 99.99%, what we call 4 nines in IT, availability over the last 3 years. We produce, we've delivered and we serve the NHS mail system, which is used by 1.4 million users. That's a very large mail system. We've also deployed NHS Teams, which we rolled out very quickly earlier this year. And then, of course, on top of all that sort of digital service delivery, NHS Digital is also the national data custodian for the system. So a huge amount of our work is collecting data, curating it, linking it, analysing it, and then disseminating it to a great number of places. And then we have a large number of legislative responsibilities around information governance. But I think a huge amount of progress has been made in the last 3 years. We are really ambitious about what we can do. I think we can be more ambitious now than we were in the long-term plan, even though it's a relatively recent document, because obviously what we've been able to do during this COVID period is go even harder and even faster, get much more effective data sharing across the system, and various other little victories. So, I think we can be more confident than we ever have been before about the potential for the digitisation of this system.
Okay, thank you. That's a positive picture. Clearly, one of the big issues in driving this change is just the vast number of legacy systems that could number 100 within a trust area itself. I mean, why is there such a proliferation of these systems? And what organisations are you learning from in terms of rationalising them?
Well, you're right. There is still a lot of legacy technology, and and there is this sort of challenge, if you like, of mass heterogeneity. So there's an awful lot of different technologies, different tech stacks, different systems in use across the various locales and the regional areas of the NHS, and it is complicated to migrate away from legacy systems. We're trying to make sure that we get the right design architecture into the system, so that what the national centre provides in terms of digital capability is as enabling as possible for the regions to allow them to make those migrations.
Mr. Wilde.
Just on, you mentioned the WannaCry. Clearly, one of the risks to all government systems, there's legacy systems all over the place, is the cybersecurity risk. How confident are you? I know obviously the updates and things from Microsoft are now happen, but what specific work have you done to assess the legacy systems and their vulnerability?
Well, we work with trusts constantly through a variety of sort of processes to assess the risk profile. We have sort of a questionnaire type approach that we use with trusts to assess what the level of risk is that they are carrying at any point in time, and we are very focused, particularly, of course, on the people who are at the bottom end of that spectrum. We're acutely aware that there remains significant cyber risk in the system associated with legacy systems. The Microsoft deal that we worked on earlier on this year is enormously helpful to that end, because it does obviously allow a lot of migration away from some of those legacy environments. Within NHS Digital, we've also put in place a number of national services that regional teams can depend on, that allow them to make the perimeter of their organisations more robust, and various other sort of technical defences that they can tap into that we've provided centrally. So, it's a long and complicated journey away from legacy, and there is undoubtedly a cyber risk associated with legacy systems. And really, the strategy just has to be to pursue with eradicating them as hard and fast as we can.
Thank you, Mr. Williams. What's the impact of the inefficiency of having these legacy systems that can't talk to each other, and the impact on patients?
Well, as our tech vision sets out, the benefits that we're looking to get from investment in digital transformation is about improving health outcomes. It is about improving patient and indeed staff experience, as well as driving productivity. So the challenge here in delivering the transformation program is about being able to identify and secure those benefits and deliver those on time. So I think I would characterise it as the legacy landscape is one of the challenges that collectively we need to address in delivering those benefits. To the extent that we are off plan, there is clearly an opportunity cost. And that's something that we take seriously through our program management approaches. But I think it's worth just having in mind that the benefits here are, some of them are financial, but they're as much about user experience, patient experience, and in the end about improving health outcomes through the NHS and indeed wider care system.
Mr. Wilde.
If I want to look at specific in terms of electronic patient record systems, PARA's page 44 in the report, PARA's 4.11 and 4.12, talk about the different approaches to replacing records, whether enterprise-wide, best of breed, or in-house systems. It seems like there's not a sort of a central steer here as to which model trust should be taking, and I'd be interested in what work is being done on the in-house design systems, for example. Is that capability that sits within NHSX to help deliver, to drive a commonality of system rather than having a multitude of them?
Who's that
perhaps,
to? Sorry, to
Ms. Wilkinson to begin with.
Yes, sure. So perhaps it's helpful to clarify for the committee the different responsibilities of the organisations here. The policy around data and systems, the policy decision sits with NHSX, and the responsibility for setting the strategy for digitisation across the system sits with NHSX. What they also do is to define the new digitised services that will be put in place. So the new maternity pathway or the new childcare pathway or whatever in a post-digitised world, they set the vision for that. Within NHS Digital, we're at the sort of technical end, if you like, where we design, build, deploy, operate systems, manage security of systems. So the process of setting out the strategy for trusts around how they make their decisions around patient record systems is much more with NHSX than with us. At the moment, as you say, there are a number of systems in existence, although some degree of market competition is no bad thing. And there remains one system that is still a sort of legacy from the National Programme for IT that is still run at the National Centre, used by about 20 trusts, and NHS Digital still operate that on behalf of the Department of Health. But I would pass over to Matthew to comment on the sort of strategic guidance of trusts in terms of system selection.
Mr. Wilde.
So we wouldn't want to see a monoculture. I think we tried that in the National Programme for IT and it didn't work. And one of the key lessons from that programme was that you need to tailor technology to the context of the NHS organisation in question. But I do think we need to provide, NAO report is completely correct, we need to provide more guidance to trusts, not just on which electronic patient records to choose, but more generally around what should be expected of different sorts of providers in health and care in terms of technology and in terms of digital transformation. So we have a project, one of the key things we're working on at the moment is a project which is called What Good Looks Like, which, as the name suggests, is precisely to set out criteria. So if you are the chief executive of a mental health trust or an acute trust or part of a health and care system, you know what it is that you need to do to reach a sort of minimal level of digitization and digital transformation. And I think that will allow us to create a much more sort of common and sensible approach across the system. At the same time, we need to make sure, even if we different trusts have different EPRs and different systems, that's within parameters. So we're doing two things there that I think will help. One is we're setting standards so that when trusts buy technology, they conform to the same technical and semantic standards so that even if they buy two different systems, they can speak to each other. And secondly, we're using procurement frameworks, both to save money using the buying power of the system, but also to make sure that trusts aren't, or bits of the system aren't making procurement choices complete in a sort of complete open, but rather from a set of products, whether it's electronic patient records or remote monitoring technology or whatever, that's vetted. We know it's compliant. We know it works.
Sure, we'll come on to standards shortly. Yeah, I want to just pick up a bit on the lessons learned from the national programme for IT, and one for Mr. Williams. I mean, the report says it doesn't consider that the lessons have been properly learned or systematically captured. I mean, what are the key lessons from your perspective about the failure of that programme?
Well, look, there've been a range of in-house reviews, lots of NAO and Public Accounts Committee interest, reviews by the government's Major Projects Authority, and indeed, as set out on page 12 of the report, through the WOCTA review, lessons from a range of programmes, which actually I think we are adopting well. I mean, the two key ones that I would highlight is the previous focus on a centralised national programme, as opposed to the approach that we're now taking, and you may come onto this, around setting standards for particular pieces of IT for interoperability, and being smarter, I think, about the balance between bounded national programmes where they make most sense and local interventions and activity where that makes sense. So moving off the sort of monolithic top-down approach. I think it's we've made improvements in, and this flows from the first point, in procurement and contracting arrangements, and I think we have got more realistic in our understanding of what can best be delivered over what kind of time frame. So on the one hand, we are ambitious for delivery, given the kind of benefits that we all see from digital transformation. But that needs to be matched with realism about the differential starting point of individual NHS bodies and some of the challenges of implementation.
Yeah, just to pick up on that, figure one, the point 3. Point 3, where it talks about this, that there isn't there's no implementation plan yet produced to deliver this programme by 2024. Is there going to be a formal implementation plan? I mean, my experience in government is that things get announced, but then the implementation, there often isn't a plan. That was kind of the mantra of John Manzoni when he was Chief Executive of the Civil Service. So is there going to be a formal implementation plan for this programme?
Well, Mr. Gould may want to come in, but just a couple of headline points from me. So firstly, the implementation plan here is a blend of what nationally we will be doing, what needs to be done by individual systems, and what needs to be done by individual NHS organisations. So it's a blended or tiered plan, if you like. NHSX set out first cut of a technology plan to deliver on the vision at the start of the year, just before the COVID crisis hit, and development of that plan has necessarily needed to be adjusted to reflect the demands of the last few months. But Mr. Gould may want to set out next steps there.
Yes, as Mr. Williams has said, we had an intention through the first 8 months of this year to produce a digital strategy for health and care. In February, we put out for consultation the first part of it, which was the vision. It was to be followed by 6 months of consultations and co-creation between the centre and the front line. Unfortunately, events intervened, but it's still very much our intention to do that. I mean, in the meantime, though, we have the long-term plan, we have a set of commitments that we need to do our best to deliver. I think it's also worth saying that this won't be delivered primarily at the national level. I think at the national level, there are certain services, particularly those built and run by Sarah and her, Ms. Wilkinson and her team, that make sense to be done nationally. I think nationally we can help the front line, we can give them parameters and support and guidance, but fundamentally this is about capability, decisions and progress made at the front line rather than from the centre. I think it's also worth saying that it's not just about the money and not just about what we spend. It's also about systems, guidance, skills, and the approach. So we are trying very hard to put in place each of those building blocks so that the front line can drive the digital transformation over the next few years in the way we want to see.
Thank you. So just out of interest, have any of you spoken directly to Richard Granger about his experiences of trying to roll out the national programme?
I have not.
I haven't, but I have spoken to a number of other veterans of the programme, and indeed some of them I work with. So those lessons are very keenly learned.
Mr. Williams, who's ultimately going to be accountable for ensuring that the NHS is digitally transformed? Who's the SRO? Who should we be focusing on in terms of the accountability for this programme?
Well, Mr. Gould, in his role, as we've touched on already, has responsibility for setting the overall strategy and plan, and in that he reports to the Secretary of State ultimately. Delivery, given the sort of layered nature of the plan that I touched on, is through a series of SROs for components of the programme, and indeed through delivery at the local level. Now, nationally, in terms of assessing progress against that plan, Mr. Gould, working closely with colleagues in NHS Digital, where Sarah Wilkinson's organisation is delivering, has the programme management function, if you like. That capability is being built up so that we have both the capability of really identifying key milestones of metrics and being able to flag where performance is off track. What action then needs to be taken will depend on whether it's a national part of the delivery or a local, and quite what the issue is. But you may want to hear more from Mr. Gould on the delivery architecture.
Yeah, it's really who. Okay, appreciate the point that this diffuse system is going to be delivered, but who at the centre is the controlling mind? Who is the person who is worrying about this every day, and is the person that our committee will probably want to keep calling back to get regular progress reports? Who is that individual?
Well, I suspect it might be all three of us, but if you had to pick one, I would pick Mr. Gould.
Passing the buck to you, Mr. Gould.
That's right.
You're in the hot seat.
Yes, I think if it is anyone, it's me. But, I mean, it is definitely a collaborative effort, as Mrs. Wilkinson has set out. I'm responsible for the strategy, and formally, I think, accountable for it and to the Secretary of State. But it's definitely a team sport.
So to add to that, NHS Digital feels completely accountable for the effective delivery of everything we're commissioned to deliver, and I feel completely accountable for that. In order to deliver effectively, we need really clear views of what the vision for digitisation is and what the strategy is and what the future digitised services will look like. But when we get that and it comes down to us to build and deliver, then I take full accountability for that.
Okay, I mean, yeah, obviously this is projects to revolutionise the NHS technology have not been hugely successful to date. One for Mr. Williams. I mean, there was a target for a paperless NHS by 2018. It's now been moved back to a target 6 years later to meet a core level of digitisation. Which doesn't sound as ambitious as some of the other statements that have come out of DH recently. I mean, why is this watered down target been put in place rather than the paperless commitment?
Well, I think it is a more realistic target. It doesn't mean that we are less ambitious in where we see the benefits of digital transformation in the NHS. But I think one of the lessons that's highlighted in the WAPTA report is that thinking of implementation in phases, recognising that some NHS organisations are already more digitally mature, others have got a much lower baseline, as it were, that they are operating from. Having a sense of ambition, but also realistic phase targets to make and really embed progress is a more effective way of delivery in this space. I think it also reflects an increased emphasis on the standards point that we have touched on. So the route to delivery is different to our previous ambitions. And there is an element of ensuring that the funding is available to match that ambition as well. Although, as Mr. Gould has said, this is not simply a question of money, but a broader-based change programme overall.
Okay, to come on to Mr. Gould, I mean, you've got this watered-down target in some ways. How much progress has been made to meeting it?
So I don't think the target has been watered down. Actually, I think turning paperless it doesn't describe the range and ambition of what we want to do. I mean, for example, one of the things we're working on at the moment is scaling up the use of remote monitoring technology, so that people can be monitored out of formal care settings in their homes or in care homes. That's not about being paperless, but it has the potential to transform the way that care is delivered, to improve, make more efficient and much better for the patient the delivery of care, particularly if they have a long-term condition where remote monitoring can really help. So I wouldn't say we've watered it down. I think we've sensibly shifted it from being paperless to actual transformation. How much progress have we made? I mean, as Mrs. Wilkinson has said, over the last few years, I think we've made considerable progress, but there's a very long way to go. There's a considerable variation in trusts. There's even more variation in the social care sector. And I think levelling up both the NHS and the social care sector has still got a long way to run.
Yeah, no, if I could just build on what Matthew's just said. I mean, I wasn't around when the word paperless, I suppose, was made central to this, but it's a bit odd. I mean, the benefits of digitisation are about improving the lives of patients and clinicians. You know, what we look at all the stuff that we have achieved over recent years, and particularly the stuff we've achieved in the last 6 months in COVID, the things that matter are, you know, radically improving data access across the system so that 111 and ambulances and pharmacists can see records from primary care, you know, providing great triage tools so that we've got 111 online and we can take the load off the 111 phone systems during a crisis, and building much better communication systems like the Teams implementation. And, you know, we've achieved massive economies of scale through the digitisation of prescriptions and referrals, and we've improved patient security. We've talked about that a little bit earlier, patient access and interaction with the system. So I suppose the point I would make is making things paperless does, of course, often make things easier, but I think it's a slightly peculiar single measure of success.
Sure, okay. Is anyone able to confirm there are no longer any fax machines used in the NHS, and that they've all gone to a cemetery somewhere?
We've taken them off the procurement frameworks. We were going to do a survey of remaining fax machines across the system, but during the pandemic, we've been trying very hard not to put any unnecessary or lower priority burdens on the system. So when we think the system has the bandwidth to be able to gather that information, we'll ask of it. But anecdotally, it's very clear that there's been a very stark shift.
Mr. Wild.
Fine, okay, thank you. I want to come on to interoperability here, and paragraph 14 says interoperability is essential for the transformation, but very challenging to achieve. I just want to pick on a couple of examples. So in the report, it says and I admit this is 2017 data, but only 15% of trusts report mostly being compliant with the standard for clinical terminology. Do you have a sense of what that figure is today?
Yeah, it's radically higher. I mean, I can't put my fingers on an exact number for you, but
in this 80% or
closer to that. It is
okay.
much higher. So I'm quite happy to drop you a note and outline exactly where we've got to with that.
That would be helpful, thank you. And then on page 46, where we talk about the local health and care record, it talks about this being delivered in waves to be completed by April 23. The first wave is launched. The paragraph 4.14 says NHS X hasn't recruited staff to allow it to do the necessary work. What is the status of that programme now? Do you have the people, Mr. Gould?
Yes, we have been and are recruiting the team to allow us to do that. It's also worth saying that we've evolved the model, particularly in the light of the pandemic. The local health and care record programme put together bits of the system, typically with populations of 3 to 5 million, to share records across that population and to make develop new pathways to make use of the ability to share it. We've focused it now on making sure that every part of the country has a shared care record in place that will allow patient data safely and appropriately to flow between different care providers, including health, but also in social care. We know it can be done because it's done very effectively in some parts of the country, but it's even more important now that every part of the country should have that shared care record in place. So we are moving as quickly as we can to create a procurement framework so that bits of the country can that need to put one in place can buy technology with confidence, produce guidance so that they know what to do. And we've changed the geography of it. Increasingly, the NHS is focusing at the system level, the 44 local care systems, as the sort of core unit of geography. So instead of insisting that we have clumps of 3 to 5 million, we've said that locally systems can decide what's the most appropriate scale to do this on, and if they want to do it at system level, then that's good as well. Okay, thank you.
In terms of standards, the report refers to only 3 of the 10 sets of standards so far identified by NHS Digital already. Why is it taking so long to define these standards? I mean, we've been talking about how to do this for about 20 years. So Mr. Gould, do you lead on the standards?
With Mrs. Wilkinson, we help, or we define the standards that need to be met, and NHS Digital will do the delivery of the standards. We also, and I think as important, I mean, a lot of progress has been made in defining the core standard, but as important is enforcing the standards and ensuring that they are followed across the system. So, for example, if you take the very, simple sounding and existing standard that everyone in the NHS should be identified by their NHS number, should be one of the big strengths of the system, that every individual has a unique NHS number and across the system they can be referred to by it. It sounds straightforward. It's been announced a number of times, but in a lot of trusts, it's not the case. And it's actually surprisingly difficult to take a system which identifies all their patients one way and turn it round so it starts to use the NHS number. So there is a lot of work to do to ensure that not just the standards in place, but the underpinning technology, the incentives, the rules, the spend controls are in place to make sure that the standards embed.
Okay, but is it accurate? It's an agreed report, so I assume it is accurate that only 3 of the 10 sets of standards have been produced. So when are the other 7 going to be ready so that people can crack on with a programme that's got 4 years to come to fruition?
I think it was accurate at the time of publication, but across a range of them, we're making progress. The digital medicines programme is now live. Transfers of care for discharge and outpatient letters back to general practice is live in testing. We've published now the National Record Locator Service specs. The event management service is now live. Pathology standards are in progress. We've got a unified list for blood sciences, and we've got others to follow. On observation standards, we've got our version 1 complete, and we want to trial it with paediatrics. We're finalising the governance for the UK implementations of what's called the FIRE standards. Across a range of the 10, I think it's not binary. We are making good progress.
I think it'd be helpful if you could just follow up with a note on against those 10 sets of standards referred to. What the latest
and actually, could you include that in that note? Any upcoming milestones that you're expecting to meet, and record where you think there may have been a knock-on effect of COVID, because we're very keen that COVID isn't a reason not to do things across government. I think Mr. Williams shares this view on the money side, so we'd just be interested to know if there is a knock-on impact and why specifically that has been the case. Mr. Wilde, last couple of points from you.
To Ms. Wilkinson, how are you expecting suppliers to develop these systems to comply with standards when the standards aren't ready? How's that going to work?
Well, they won't be able to find.
Yeah.
But a lot of standards are ready, as Matthew said. The process of defining standards is a sort of very large and problem without very clearly defined edges. So much work has been done to define standards, and NHS Digital has done a lot of work with the supplier community where those standards are defined.
Yeah,
fine. Should be implemented. So, for example, the the new procurement framework that we issued at the start of this year for primary care IT system suppliers is much clearer than any framework we've had in the past in terms of what's required from a standards perspective in those systems. And the supply community, by and large, has embraced that journey.
Okay.
You need to
Okay, Mr. Wiles.
Sorry. I might come to the end of my session shortly, but paragraph 15, Mr. Gould, says that NHS X does not have a time frame for achieving interoperability and its plans are underdeveloped. How long do you expect it to take to achieve interoperability between systems?
So it's not a straightforward question because, as you said, I think you said individual trusts could have 100 systems that don't speak to each other. Actually, I've seen trusts that have closer to 400 systems that don't speak to each other. We have an enormous legacy estate, extremely complex and distributed. Even if we put in place standards, and even if we enforce those standards and ensure that all new bits of the estate are compliant, it will take years for that legacy estate to catch up with the standards. It will be replaced and sorted out bit by bit. So look, I hope in 5 years' time, we will have a much more interoperable system than we have now. We will, sooner than that, have shared care records across the system to allow data to flow. But true interoperability across the system is a work of years.
Okay, but it's quite difficult for us to hold you to account if there isn't a target. So you said 5 years there for high level of interoperability. I mean, I think we're looking for a bit more of a metric that can be, that you've been nominated as the person that you can be judged against to meet. I mean, can I press you on that?
Yes, and I mean, I think we need to, look, we can certainly come up with a metric for shared care records and the flow of data. So in terms of the impact on the patient and direct care, ensuring that data can flow between care settings, we've said that we want all 44 systems to have in place a shared care record by September next year. That will be a stretching target, but we'll do our best to give systems the support they need to reach that. So I think, look, that would be the key target, deeper interoperability and getting away from the legacy estate and the extraordinarily patchwork system that we start with. I don't want to put a timescale on because I really think it's a sort of complex and hard to pin down job.
Okay, on operability, I just want to pick up on the opportunities of the cloud and cloud computing, and particular opportunity around vendor-neutral digital image sharing, where there'd be big benefits for patients, radiologists, consultants. I mean, how can NHSX ensure that opportunity to use technology so you can get images to where there's capacity to tackle screening delays is taken up by trusts?
So I think there are numerous ways. I mean, number one is we can put in place, ensure the policy and standards facilitate the use of cloud and the ability to share images in the way that you describe. Often they were written pre-cloud and they need to be brought up to date, and we need to make it easy for bits of a system to be able to move to that technology. I think secondly, and Sarah's team has done outstanding work in this, we can ensure that there's the connectivity in place, the bandwidth, so that this can actually work. I mean, these are sort of heavy bits of imagery to move around. So we need to make sure that the bandwidth allows it. We can make sure, and this is, I think, really important, that the care pathways make use of the technology, so that when we design or redesign a care pathway, that it takes account of the opportunity, as you've described, to use technology to provide a more efficient service and create better outcomes. So that there are a range of ways that we can do it.
Okay, because I've got a constituent who's involved in a company that does it widely across the independent sector. Ironically, it's doing it across the independent sector where the NHS has been paying. Does it with some trust, but it's getting real problems with getting traction. They've had some conversations with people within your organisation who are favourable, but then this opportunity just seems to sort of melt away. So I'd be grateful if perhaps offline we could have a separate conversation about how standards can be used to make sure, not for my constituents' company, but across the board, that this technology can be used, because I do think the way that it has been operating during COVID has been successful, and we can do more on that. So if you're amenable to that, Mr. Gould.
And
I'd be
Mr.
very
Gould,
happy to.
as an MP for Shoreditch, I put in a plea there. I have similar business to Mr. Wilde, struggles to get in, to understanding how to get into the system and work out how they can get onto the platform. Mr. Wilde, are you nearly done?
Yes, sorry, okay, just coming to the final for a bit of my section now. There's clearly a bit of a tension here, Mr. Wilkinson, in terms of a bit of the legacy systems, is between getting on interoperability, but also trying the aim of increasing suppliers into the system. So how is that tension going to be managed so that we avoid some of the problems that you are now having to deal with, but also do open up the system to new innovative companies?
Well, obviously, moving to sort of open interoperability standards will free up the market, because it makes it, if we're very clear how we expect vendors to provide interfaces into their systems, it's easier for other vendors to develop services into the market and interconnect with those systems. One of the things that makes it most difficult, as you were alluding to earlier, for new providers to come into this market is the complex work of integrating with a large number of other systems in the health environment, some of which are not hugely interoperable. So, I believe interoperability is an absolutely critical foundation condition for creating a vibrant, competitive market for healthcare technology. The legacy systems are, difficult to migrate to modern international standards. There's no question about that. But I think we've got to, as I said earlier, there is no easy answer for managing legacy. You just have to have a clear plan for getting off each legacy environment, and you have to keep going till it's done.
Okay, the final question from me, Chair. I mean, local organisations are being asked to build a data layer, but my understanding from the report is the work has not been done yet to define what's needed for that to be successful. Is that correct?
May I answer that? It's finding expression in the shared care record programme that I described earlier, where we want to make sure, as I say, that each of the 44 systems have in place shared care records so that patient data can flow. We're defining standards, we're creating a procurement framework, we're providing a measure of funding and support so that that can be put in place very swiftly.
Thank you very much.
Okay.
Thank you. If we've got time at the end, Mr. Wilde, I'll bring you back in. Now we need to move on, and if I could urge our witnesses, we had a really interesting part of session there, but we do need to keep an eye on time. So if you could keep your answers a bit shorter, and Olivia Blake will set the example with some very pithy questions. So over to you, Ms. Blake.
Yes, Chair, let's try and keep this to a quick fire round. This first question really is to all three of you. How is the relationship between NHS England and Improvement and NHS Digital functioning? So start with Mr. Gould.
So I would say it's a work in progress, but it's getting better all the time. What we've learned is that we need to have clarity of role between NHSX and NHS Digital, and as Sarah has described, I think we're getting there, and it's getting better and better. We've also learned that it really improves to embed a digital transformation mindset in NHS England and Improvement, so that it's not just tech people talking to tech people, but whether it's on the clinical side or the transformation or the people side, tech is properly embedded. So one of my functions is to be NHS England and Improvement's National Director for Digital Transformation. And it's an absolutely core part of the role of NHSX to ensure that it is NHS E&I's Digital Transformation Directorate, and we've got digital transformation, I mean, really firmly helping to drive what NHS England does.
Mrs. Wilkinson?
So I completely agree with Matthew. It's a work in progress. I mean, I think it's complicated. It's very complicated inserting a new organisation into a structure that's already very, very complicated. And of course, NHSX has a sort of upstream interface with NHSE and NHSI, and a downstream interface with NHS Digital, so to speak. So getting all of that right isn't dead straightforward. We did put in a lot of work in sort of autumn and winter, Matthew and I personally, to working out what the boundaries should be between the roles of the different organisations and documenting that and socialising it. And we're both in agreement, and we were both very committed to making that work this year. I mean, the honest truth is in the last 6 months, we haven't looked up. We've been so consumed in NHS Digital with building services specific to COVID. We've had very little time to spend looking at rationalising organisational design and eradicating some of the overlaps that had emerged early between X and D. But I think we're all committed to a direction.
Okay.
As Matthew says, it's a work in progress.
Ms. Blake.
Okay. Can I ask if there's been any unforeseen difficulties in the relationships?
Ms. Wilkinson.
We find
Shall I go to Ms. Wilkinson, because NHS Digital was there before you, Mr. Gould, so we'll do it in that order. Ms. Wilkinson.
Yeah, look, I mean, as I say, it's not a straightforward process inserting a new organisation into a very complex structure that's already very complicated. So, of course, there are still tensions in the model, and there are still things that we need to iron out. But as I say, we're completely committed to where we need to get on this, and we have started on that journey.
Okay, Mr. Gould.
I agree with Sarah.
Okay.
So we can just ask, you agree, but you're saying there are some tensions. Perhaps you could just both give us a couple of examples of the tensions and how you're trying to resolve them. Ms. Wilkinson first.
Just overlaps at the moment in terms of work that is being done, and I think we will refine that, and we will get to a position where there are sort of less people from both organisations trying to act in the same space, which becomes inefficient, and decisions get made a little less quickly. But it's relatively nascent as a structure, and it's very complicated putting something new into this structure. And I think, had COVID not happened, I think we might be in a position now, sitting in front of you, saying, it really works quite smoothly. We've really made not much progress in the last 6 months, but hopefully for understandable reasons. And we just at some point need to get back to refining the two models and ironing out the problems that exist today.
Okay. This question.
Does Mr. Gould want to add anything to that? Do you want to add anything, Mr. Gould?
I mean, only that, as Sarah has said, we are bit by bit clarifying sort of who does what. So if you take an area like architecture, for example, it's very clear that Sarah and her team lead on the technical architecture. My team will lead on the enterprise architecture, so how the bit Sarah builds sort of fit into the whole. And I think what had been a bit messy has become increasingly clarified. So as Sarah has said, we're making progress defining where D stops and X starts and vice versa.
There's a phrase there about D-stopping and X-starting. I'm sure we can play into our report somehow. Ms. Blake.
Just quickly then, in response to that, how long do you think, given the current circumstances, it will take for you to get to that point?
Well, I mean, one of the problems that I have at the moment, to be perfectly honest with you, is when we started our COVID programme, and we had a whole bunch of things we had to do in the first part of this year, the 111 platforms and data to research, and all of the new remote access architectures, and building the infrastructure for test and trace. I thought we would be that would be a huge chunk of work in the first half of the year, and it would be slightly lighter in the second half of the year. That unfortunately was very wishful thinking. We now have a massive agenda to the end of the year, because we're working on the vaccinations platform, the risk stratification for vulnerable people, ongoing remote care, and replumbing 111 to allow for booking into emergency settings. So there's a massive body of work, and I really have to keep everybody in my organisation focused on that. That is what matters. And you need to resolve organisational and operation model issues. Laura Wade-Geary is doing a review over the course of the next few months, looking at the ambition for digitisation of the health service, and as a part of that, she's looking at operating models. So that would help. That would give us an independent perspective. But refining organisational model nuances is not my highest priority right now.
Okay, thank you, Ms. Wilkinson. Mr. Gold?
Look, I agree with Sarah. There's an awful lot to do at the moment. Laura Wade-Geary's review, I think, will give this process a boost. I mean, crucially, as you alluded to in the original question, it's not actually just or even primarily about X and D. It's about the whole system and ensuring that digital transformation is in the whole. And so the Wade-Geary review emphatically is looking at the role of E&I and how we can make sure that whatever bit of the centre thinks about a problem, whether it's a new approach to cancer or whatever, the opportunity of digital technology is inserted from the start rather than tacked on as an afterthought.
Ms. Blake?
Okay, Mr. Williams then. Please can I ask just a bit about why the department felt it necessary to introduce NHSX, and do you think that we have a bit of an overcomplicated system at the moment, and how would you justify that?
Mr. Williams?
Well, from a departmental perspective, what the establishment of NHSX has done actually I think is a helpful clarification at the national level about responsibilities for strategy, for the vision, for the overall direction, rather than having that sort of strategic customer function, if you like, split between the department and NHS England, NHS Improvement. So having a single voice reporting to the NHS England and Improvement Board and into the department and the Secretary of State on the tech vision, what good looks like, actually I think has been a really quite helpful decluttering, if you like, of the landscape. It also means that within the department where previously the tech portfolio for our own interests, as it were, the director or deputy director level, that we have through Mr. Gould's joint appointment, a senior civil servant. He sits on our departmental board, in effect as the departmental CIO, which gives us a more senior focus for these issues within the department, which would otherwise, I think, be harder to sustain. So primarily around clarity on strategy and ownership, and embedding some of that in the wider thinking and work of NHS England, as Mr. Gould has said, whilst at the same time allowing us within the department to up our own game.
And just to, obviously we've heard about duplication. Why do you feel that NHS Digital was unable to fulfil the roles that you've just outlined?
Well, for me, it's about the distinction really between a strategic client setting direction, setting the requirement, and the critical role that Sarah Wilkinson's organisation plays as a technology supplier and implementer. So it's a different function, I think.
Okay, you've touched on this, but can I ask a bit more about how you feel the lines of communication and responsibility are functioning, and if they are adequate for the size of this project?
Well, look, picking up on points that Mr. Gould and Sarah Wilkinson have made, I mean, yes, there are still aspects of the organisational structure, the boundaries between organisations here that are a work in progress. Some of that, I think, will absolutely be in scope for the review that Laura Wade-Geary is conducting, and she will, present her findings and no doubt recommendations to the Secretary of State later in the year. But as Sarah in particular said, and I absolutely agree, there's plenty to get on with in the meantime. And under her leadership and Matthew Gould's leadership, both organisations are focused on practical implementation and delivery rather than the sort of border skirmishes, as it were.
Okay, and can I ask, because we didn't really touch on this before, if Mr. Gould and Ms. Wilkinson feel there's any tensions between the department and their two organisations? Mr. Gould, you first this time.
I think that it's functioning broadly smoothly. That's not to say there aren't issues, there aren't discussions, but I'm happy with how it's working. I think the creation of NHSX has, as Mr. Williams said, given a measure of unity to the strategy and the direction. We're still developing how we use that, but I mean, no, broadly, I think it's functioning broadly well and getting better and better.
Ms. Wilkinson?
I mean, I feel NHS Digital enjoys a very positive relationship with the department.
Okay, anything you'd like to see improved? I mean, there must be practical day-to-day tensions. You, Ms. Wilkinson, first.
I mean, they could always provide us with more funds.
Okay, so there you go. There's your bid. There's Mr. Williams. You've got all that money sloshing around for Moonshot. Perhaps give a bit to Ms. Wilkinson. Mr. Gould.
I think, I mean, as Sarah said earlier, we need to do a better job at ensuring that when we ask NHS Digital to build things and to run things, there's real clarity and unity around what's required. So we're strengthening, for example, our approach to SROs. So we're putting in place a strategy to ensure that we grow the cadre of SROs with the training and capability we need. We're strengthening our project management office to make sure that we track, monitor and run projects most effectively, so that Sarah can have the clarity of purpose that as a delivery organisation she needs.
Okay. Can I go back to Ms. Wilkinson? You said more money, but as a sort of throwaway mark, but what would you spend that money on? I mean, to be really clear, what would you like to be able to do that you're not able to do at the moment?
Well, to build on Mash's point, I mean, the single biggest sort of critical success factor for us is clarity of commission. You know, one of the difficulties really where we've run into difficulties on project, it's been getting absolute clarity from commissioners. You know, whether that was NHSE prior to NHSX or NHSX, or indeed all the other ALBs we support. Our job is to codify things. You can't codify things that are sort of conceptual, and you know, people need to be very specific. And redesigning complex pathways in the health and care system to digitise them is a really tricky business, and it requires a huge community of people to be brought together, which Matthew is quite extraordinary at. So we need to get that clarity, and that allows us, I think, then to get clear instructions and to crack on with the build. In terms of what we would spend it on, I mean, we are a commissioned organisation. It is up to Matthew to determine what the priorities are for digitalisation, and we will build according to the priorities that are set by NHSX. You know, we obviously would love to have more money to spend on the digitalisation of social care and to enhance some of the interoperability agendas, to build that, to move away faster from the legacy systems, but there isn't an infinite amount of money for technology, and that complex problem of prioritising what matters most, I mean, thankfully sits with Matthew, not me.
Okay, thank you. So just moving on to back to Mr. Williams, if that's okay. We've established who has responsibility for the project, but I was wondering how the department is tracking delivery of NHSX, given that it's an unaudited body, and what the department is doing to make sure that money is being well used. Mr. Williams.
Yeah, so the national spend that sort of Mr. Gould has at his disposal either turns out to be sort of departmental funds, particularly on the capital side, in which case the normal departmental processes for resource allocation and monitoring the spend apply, or it's spend that falls to NHS England and is overseen by Julian Kelly in his role as Chief Finance Officer for that organisation. I think it is an area that we should keep under review. We're looking both in terms of resource allocation, really to empower Mr. Gordon and his organisation to prioritise within a budget. He's touched on programme management and development of SROs so that we can have delivery aligned to the way in which money is spent. So for sort of practical day-to-day purposes, the responsibility sits in NHSX, but in terms of the auditing point, it either comes through NHS England's accounts and then into mine, or directly into the group position.
Okay, thank you. Do you think that more needs to be done to kind of be able to hold both NHS Digital and NHSX to account from your department?
Well, I think I mean, just building on your finance point, I mean, the budgetary arrangements for digital transformation are not straightforward. It's in the nature of tech spend that some of it is revenue, some of it is capital, and those are different budgets in terms of how the Treasury and Parliament votes resources to the department. Balancing between those, balancing between national and local spend is quite a complex process. So I think continuing a direction of travel in which there is a tech envelope within which NHSX is able to prioritise and commission, setting clear budgets for NHS Digital within which Sarah Wilkinson's organisation is able to deliver is part of that sort of continuous improvement of the relationship.
Okay, I understand that it's not established by statute. Can I ask, therefore, where the responsibility actually lies if something was to go wrong? And also, sorry, if you believe that this should be.
So, Mr. Williams, you're the accounting officer for NHSX, effectively. I mean, in all reality.
Well, the money that Matthew spends splits partly between money for which I'm directly accounting officer and money that is spent by NHS England, for which Simon Stevens is the accounting officer, although then obviously his position consolidates into the group space. I think the point in part is that what Matthew's joint appointment is doing is discharging a range of departmental and NHSE functions which themselves are distinct, but through a single appointment and a single team. And in that sense, the relative sort of letters of delegation and accountability are set out. Getting the money tidied up so that he has more authority and with that some accountability for how prioritisation decisions are made may be worthwhile. But again, back to in practice it is working okay. It is getting better with practice. It's not the most important thing that I want to
I like clear line. This committee, as you know, likes to know that we can follow the money through. So we'll keep an eye on this one. Ms. Blake, back to you.
Moving on to the kind of communication and work between the local areas and the national programme. You mentioned procurement and standards. Who is responsible for the sign-off at a local level, and what oversight do you have of this nationally?
Matthew, do you want to pick that up?
Yes, so I mean, typically it would be the chief executive of the organisation in question. Mental health trust chief executive would be responsible for or ultimately accountable for the purchase of, for example, new electronic patient record system. There's a business case approvals process in place for spend above a certain level. We are putting in place a spend control system to make sure that the spend is compliant with the standards we set out. We have been putting in place a series of procurement frameworks so that it can be done quicker and more easily and more confidently, and putting in place a variety of programs to train staff and so that they can have the confidence to engage with this process more than they do at the moment. So it's a local accountability, ultimately sits with the chief executives of the organisation, but we're keen to support them so that they can make better choices with more confidence.
This is to Mr. Gould as well, just following on from that. What levers do you currently have over STPs or ICSs as they consider technology investment, and also is there any circumstances where you would be allowed to intervene in local systems to prevent or advise anything that was out of step with the national strategies?
So this goes to the point around why we need to have that join up between the central organisations, right? And particularly in this case, NHS England and Improvement. The Phase 3 letter that Simon Stevens and Amanda Pritchard sent out to system included in it a set of requirements on data sharing. So that was an example of using the levers inside NHS England and Improvement to set out requirements to drive change. For me, it's a model of how we want to do it. In terms of how we would intervene or stop, well, I mean, we have, as I said, there's a business case approvals process for particularly large tech projects, but we are keen to put in place a more nimble spend controls process for much more of the tech spend that will allow us both to support and to ensure compliance of tech spend by systems and providers.
Okay. Ms. Blake?
Thank you. Just to build on that, you mentioned earlier that you don't want to be monolithic, but also that you're going to have frameworks. What if your frameworks don't meet the clinical need, and how many different frameworks do you imagine there being for different care settings?
So if they don't meet the clinical need, they will have failed. One of the core lessons of the national programme and in the WACC review is clinical engagement. From everything I've seen, one of the core criteria for success is clinical involvement. So if, for example, I've mentioned it before, we build, we are in the process of building a procurement framework for remote monitoring technology that we're about to launch, which will bring procurement of those bits of technology down from 3 months to 3 weeks. And systems and providers will be able to buy it with a lot more confidence than they can at the moment. That's emphatically been done with clinical colleagues and actually with the clinical lead. Again, I mean, this won't work if tech is in a silo. It will only work if clinicians are driving the need, helping us get the standards right, get the procurement frameworks right. In answer to your question about how many, there is a danger of proliferation of frameworks, and if you have too many, it can be a bit bewildering if you're sat at the front line wondering what to buy. So we've set up a strategic commercial function in NHSX with a brilliant commercial director who is ploughing through the landscape to try and work out with colleagues in NHS Digital and NHS E&I and the department how we can make sure the system is optimal. We have the right frameworks and the right number of frameworks.
Thank you. Ms. Blake?
Okay, can I ask also just about procurement? Do you think that the funding currently backs people who are good at writing procurement strategies and business cases and is leaving some trusts who are weaker in that skill set behind? Because it does seem like the approvals process might be leaving some trusts behind from what I can see. And can you confirm the way that you work differently with different trusts at different levels? Because obviously some are very far ahead and some are very far behind.
Okay.
So, yes, there is always that danger that some trusts become very expert at seeing opportunities for funding and grabbing them with brilliant business cases. And those that might need more help don't have that skill and capacity. And what are we doing about it? Well, I think there are two main shifts. One is we are trying to make the paperwork proportionate. So whereas in the Global Digital Exemplar Programme, we have moved from supporting the top trust, the most digitally mature trusts, those that are less digitally mature but want to raise their standards. The agreement letter we've brought down from, I think, something over 100 pages to more like 10 pages, so that it's more manageable. And if you're at the front line, you don't get drowned in requirements and paperwork and process, when actually we need that bandwidth to be focusing on the delivery with the right level of assurance in place. The other thing we're doing is, as I just mentioned, moving the focus of the effort from helping those who are already good to get better, which I think we've done with real impact with the Global Digital Exemplar Programme, to helping the rest catch up, and a levelling up agenda, which is the next chapter of provider digitisation.
Okay, thank you. Just one final point, if that's okay, Chair, just about whether you feel that your three kind of departments and organisations are nimble enough to react quickly to new products, particularly around new care pathways.
I would have worried more about that pre-COVID, but we have taken on large numbers of completely new, significant elements in our tech stack in the last 6 months, and we've done it fast and we've done it efficiently and delivered right results. I think we've learnt what we can do. I think we're massively more confident coming out of COVID than we were going in. So I think we are, as I say, we are nimble. I know that's been a fear of people looking at the system from the outside, but I think we know ourselves now that we can adapt very quickly to new technologies.
And if I could agree with that, I think COVID has shown what we can do. In a few weeks, for example, we put together the NHS data store to give the NHS much more better and more granular detail of what was where there were needs in the system.
So you've learned, the key thing is you've learnt lessons. I'm just aware of time and we do need to move on. Mr. Williams, you were nodding, so presumably you agree.
I agree.
You agree. Thank you. If I can, I think we need to move on now to the money, Mr. Williams. So I'm going to focus on you, if that's okay. Well, it's not okay. It's your job. There's £8.1 million set aside between now and 2023-24. Do you think that's enough for the department to achieve its ambitions? Is it going to make it work?
Look, I think so. It's more than we've previously allocated. It will allow us to make good progress. I think it's in the nature of a portfolio like this that some things will turn out to be easier than you expect, and some things will be harder. I would also, I think, just caution against seeing this as being a point at which the shutters then come down. Investment in technology, in digital capabilities, is going to be an enduring feature of life in the NHS, and the trick for us is to really carve out a sustainable pipeline over the medium term.
That sounds great words, and I think we all agree with the sentiment, but you have underinvested in the past, so how can you convince us that you've got it in the right ballpark, and all this digital transformation that was already being planned in the light of a post-COVID world where, as you've just said, we're going to be doing things more digitally generally as well. So are you confident that this is enough?
The money set out in the report is the money that we have allocated. There is a spending review this autumn which will confirm some of those assumptions we have made one way or the other. On the COVID point,
can I just ask? Is it you talk about the spending review? Is this ring-fenced money in any way? Because You have had a lot from COVID. We know the Treasury always gets jumpy about departments spending money, and they will be looking very closely at your spending. So, sorry, the bell is ringing. That's confusing.
Yeah.
So is there any danger the Treasury will make you raid this budget to backfill some of the COVID spending?
Well, generally speaking, the approach that we're taking with the Treasury is that they are meeting the net additional costs of COVID through additional resources over and above our baseline budget.
At the moment.
So I'm not particularly expecting pressure here as a result of that. The resource elements of the programme funded by the NHS are part of the Long Term Plan funding settlement for the NHS that has already been agreed. The particular piece that we need to settle this autumn is the capital component. So bits of it are more locked in than others. Just on your COVID point, though, although there will be some disruption to some plans as a result of COVID, as I hope you will have taken from some of the evidence from Mr. Gould and from Sarah Wilkinson already, there have nevertheless been lots of things that we have been able to advance in terms of remote technology, digital consultations, and so on. Digital capability has absolutely been at the heart of the NHS's response to COVID. So there are things there that we can build on and bank as we look to the programme going forward.
So we touched on capital, we touched on resource. Obviously, a major part of the resource is from trusts directly, because as well as the 8.1 billion, there's an extra 3 billion expected to be contributed by trusts. We know how squeezed they've been. Let's not rehearse the arguments about the capital funding in that sector. How will they afford this? Is that, it's in the plan, but is it really there? And is it clear, crucially, is it ring fenced for this? Is there any ring fence money in the NHS plan?
It's not specifically ring fenced, and I suspect actually from trust it's more likely to be match funding through resource spend rather than capital specifically. Roughly half of what we spend on tech is resource rather than capital. So as trusts return to financial stability, they will have more headroom to invest in this area. As you know from previous hearings, trusts have a range of financial challenges, some doing better than others, in the same way as some trusts are more digitally mature than others.
Indeed, my own hospital, Homerton, is right at the cutting edge of digital, and neighbouring trust down the road, the Barts in London, still very proud of its paper records, quite extraordinary. But I make my local point there. Can I just say, though, you talk about how they were affording, you talk about the range of financial situations in trusts. We know the top 10 are in a really difficult state. Even with the write-off of their debts earlier this year, they're still going to have that structural problem. So are you going to be doing anything to particularly help those on digital, because it's a pretty important, pivotal pillar of future NHS work, as you've just described, particularly as COVID has thrown up?
Well, look, we're currently in discussion with colleagues in NHSE around the financial framework for next year and beyond. And as you appreciate, with COVID, we've moved to a different financial structure for trusts this year, just to reflect the need to deal with a range of unplanned pressures. So the availability of trust funding, ideally on a match-funded basis, is absolutely part of the refinement and finalisation of plans that we need to do post-spending review. It isn't just about money. I mean, you need the availability of the money. It's about trust understanding what good looks like. It's about having that leadership buy-in and bandwidth to deliver. I think
which I'm going to bring in Mr. Gould. I'm going to bring in Mr. Gould on that, because as well as an understanding by trust, Mr. Gould, one of the other issues is the digital skills in the NHS workforce. So can you touch on that, the point that we were just discussing, and whether there are going to be enough skills in the future, and how you can help backfill that from NHSX?
Yes, so to start with the point about trusts funding digitisation, I think one of the issues which has inhibited this in the past has been a lack of clarity around what trusts are expected to pay and what comes out of a centre. And I think one of the most useful things we can do is a project we're calling, imaginatively, Who Pays for What, which will set out what it is the responsibility of providers to pay for and what they can legitimately look to the centre for. Because I think what has happened in the past has been providers who are sort of finite resources, hoping that the centre will come up with a pot of cash for digital that will save them from having to do it, and as a consequence, not invested the money that we would have liked them to. Yeah. So clarity on that will definitely help. On skills, absolutely, this is as much or more about people than the technology, and we are ramping up our spend on the Digital Ready Workforce Programme with a real focus on, number one, training up and giving confidence to chief executives, boards and the leadership, so that this is owned at the leadership level where it needs to be. And number two, the professions, so the Chief Information Officer cadre and the Chief Clinical Information Officer cadre, so they get the training, the support, the approbation that they deserve, and we can turn them into real professions where their skills are valued as,
okay.
For example...
Well, then this is all good stuff, but we talk about this all the time. Every sector every department we talk to, every sector we look at, there is a huge shortage of digital skills. We've got the whole risk of cyber attacks. Realistically, practically, how are you going to make sure that the NHS as a whole has the right people? I mean, for all those people who are out there who are losing their jobs, are there opportunities here for people to be trained up? I mean, because some of these jobs take quite some time, are quite specialist. Can you talk the talk there, but how are you actually going to get the bodies on the ground to do this work?
So in terms of figures, in 1920 we put 3.5 million into the training element of the digital portfolio. This year we've well over doubled that to 9 million. So it's we're ramping up, and I expect to ramp up still further. Absolutely, we should be creating the pathways for people to be able to come in to train up and to be part of this. As you say, it's not a short process, but I think if we can put these elements in place, the professional pathways, the training, we can ensure that there's buy-in from the leadership. That's much more likely to happen than just a central diktat. Yeah.
And what about at this cyber end? I mean, there is a real risk with all of these new systems. How are you going to make sure they're secure enough at design, but also that you've got the top cyber people for whom there is enormous competition across sectors and indeed worldwide to grab them and their skills?
If I perhaps go first and pass over to Sarah, I mean, I would say, first of all, we need to work out what cyber skills you need in which place. So at the trust level, you need to know that each trust is doing the basics, is keeping their cyber hygiene correct, is fulfilling those sort of core things that you want at that level. And then you want to create national capability, both inside NHS Digital, which Sarah has done brilliantly, but also drawing on the national capability in the National Cybersecurity Centre, so that the top-end expertise has line of sight to and can be drawn on at the local level. So it's knowing sort of what you do at which level will be key, rather than trying to turn every acute trust into a sort of cybersecurity hothouse. Okay,
would you want to add very quickly, Ms. Wilkinson?
Yeah, well, I mean, I would agree with that. Cyber is clearly one area where we desperately need skills, but it's by no means sort of radically harder than some of the other areas. And we do, of course, have the problem that salaries for highly skilled digital staff typically have been much higher in the private sector. But what I do think, and I would just take a minute to say this, is that the opportunities we have now in the NHS to do extraordinary digital work are higher than they've ever been. And I do very much hope, and I'm already seeing it, that people in the private sector are seeing this as the moment in time to move into the NHS and bring their skills with them. We've proved this year what an extraordinary institution it is, and what we need now is all those digital skills behind us.
Okay, and I mean every trust we've looked at the WannaCry attack. There are cyber plans in place, but can we just be clear? I don't know who would be best to answer this. Are you confident? I guess it's Mr. Gould, or maybe not. that each trust has its own proper digital plan, and or not just a side plan, but a digital plan, especially bearing in mind what you were saying, Ms Wilkinson, about how COVID has moved things on so fast. Perhaps I'll go to you first and then very briefly to Mr Gould if he's got anything to add, but only if you've got anything to add, Mr Gould. Ms Wilkinson.
Yeah, so as I said earlier, we are tracking the risk profile of each of the trusts, and we do absolutely want. I mean, cyber security is the responsibility of the local trusts, but we want to lean in and be as helpful and as facilitative as possible.
Okay, but so you're confident they've all got a clear plan now? Who monitors that? Which of you is responsible for watching that they've got a proper cyber plan?
The trusts are responsible for their own cyber, fortunes, so to speak. But we do monitor that. We do engage heavily. We do provide additional national services. And where anybody reaches out to us to say they need additional help, we always find a way to give that.
Okay, well, probably we need to go into that further at another hearing. Mr Gould, very briefly, because time is ticking.
Just to say, I mean, one of the things that gives us confidence is we've rolled out, and Sarah and her team have done a brilliant job at this, advanced threat protection across now 97% of the digital estate, which means that we actually have live visibility of, for example, are there patches being done at the front line and so forth.
Okay, so that live visibility is sort of a central oversight. That's really helpful to know. Thank you very much for that. My last question then is to you, Mr Gould, about the costs and benefits of the options for electronic patient records. The report is quite clear that you don't really have a good grasp of what the potential long-term cost benefits are, and that's one of the critical ways of selling this to trusts. Why don't you have that data, and are you planning to do an exercise to look at that so that we see what the long-term potential savings are?
So, I mean, absolutely, we are, and not just planning, we are doing it. As I say, I've set up a strategic commercial function. We've got this project of what good looks like, so we can set criteria, and we will absolutely underpin this with our best understanding of different products and different approaches, the costs and the benefits of each.
So you're doing it. When will we know? When will we have some figures? When can the National Audit Office, or when can you write to us with information about when we'll have a proper understanding of the costs and benefits of this major change?
On the electronic patient records in particular,
start with that one.
I would hope within 6 months we would be able to give you at least a first cut of our understanding of costs and benefits of different approaches. We're working on a commercial strategy for that now.
Okay, and you'll be no doubt engaging with those frontline users in hospitals and GPs and so on to make sure that it's not just cost benefit, but they're bought into it. Because we've seen problems with this with GPs not being convinced, for instance, things like choose and book in the past. So part of that will be engagement with the front line.
Absolutely. I mean, our whole job is about engagement with the front line. There's a very low limit to what we can do sat in the centre. The success or failure of this rests entirely on the front line.
Yeah. Well, if in other times we would have had a pre-panel set of witnesses from the front line. Unfortunately, with the restrictions, it just makes it a little more difficult. Though we are ever ambitious to go back to our normal ways of working. Can I thank you very much indeed for your time? I'd just like to ask Olivia Blake and James Wilde if they want one last quick point. Ms Blake, to you first, and then to you, Mr. Wilde.
Just one very quick question following up on one of Meg's earlier questions. Has anyone done any assessment of the long-term financial difficulties and productivity and tech capabilities of these struggling trusts, and whether or not the funding structure is actually a structural issue compounding the issue? Mr. Williams.
Yes, let me answer that. So, as part of the long-term plan and the commitment to return the provider sector to financial balance, NHS E&I, England and Improvement, have a plan for engagement in with the most financially challenged trusts. As you say, in some cases there are structural issues, sometimes related to previous private finance deals, sometimes related to the local health economy, not all of which are within the easy management gift of the leadership of the individual organisation. So the recovery plans and financial trajectories take that kind of differentiation into account.
Okay, Ms Blake. Okay, well. Look, we'll leave it there, I think, for now. We'd love to continue this on, but we will be coming back and looking at this again. Can I just, on behalf of the committee, pass on my thanks to all of you and for your contributions to tackling COVID. We are obviously here to scrutinise and, if necessary, criticise government failure, but where you've been putting in the work, we do recognise that, and I'd like to take that back to the department if you could, Mr. Williams. We do appreciate that civil servants and others at the front line have been putting in a lot of work to support us all, and very best of luck as we see this surge in cases, which is no doubt going to keep you all very busy. Order. The committee is now concluded. Thank you.